fat-soluble vitamins. So as we all know, vitamins are broadly classified into fat-soluble and water-soluble. The fat-soluble vitamins include vitamin A, vitamin D, vitamin E and vitamin K. So starting off with vitamin A. Vitamin A deficiency can lead to blindness in infants. So that is the inability of the eye to adapt to reduced light conditions, which is also called night blindness. The recommended daily allowance of vitamin A ranges from 420 to 800 to 1000 μg of retinol equivalents. That is for adolescents and adult females and males. Whereas for pregnant ladies, it is from 200 and 400 μg of additional intake respectively. So if the deficiency is mild, the manifestations include night blindness, xerophthalmia and keratomalacia. Hyperkeratotic changes in the oral epithelium of adults have also been noticed. Follicular keratotic changes have also been described in naturally occurring vitamin A deficiency. So vitamin D deficiency can also affect the sense of flavor and taste. So it is required for normal sensing of taste and its effect is exerted at the receptor level. This happens due to the role of vitamin A in the biosynthesis of certain mucopolysaccharides that are present within the pores of taste buds and also in the various secretions of the oral cavity. So when taste and sense flavor is compromised, it leads to poor appetite and lower food intake, which in turn leads to malnutrition. If vitamin A deficiency were to cause changes in the human tooth bud, it would occur before the 6th year of life, since by all the crowns of the teeth have erupted except the third molars are completely formed. So a lower intake of vitamin A has been associated with decreased oral epithelial development, impaired tooth formation, enamel hypoplasia and periodontitis. So next, continuing with vitamin D. So as we all know, it is directly obtained from sunlight. It is commonly referred to as the anti-curatic vitamin. So in the flowchart, we obtain vitamin directly from sunlight as 7-dehydrocholesterol, which is further metabolized to cholecalciferol. And in the liver, it again forms as 25-hydroxyvitamin D3, and in the kidney, it again forms 1,25-dihydroxyvitamin D3. So calcitriol is the active form of vitamin D. It is the sunshine vitamin and is normally made in the kidney. Although vitamin D is best known for its control of calcium and bone metabolism, it is hypothesized to have a variety of other biological roles, the most significant of them being the anti-cancer effects. Population-based relationships between low vitamin D status and increased cancer risk is now generally accepted. So, the recommended daily dietary allowance of vitamin D from infancy to puberty is 10 μg of cholecalciferol. The recommended daily dietary intake tapers off to 7.5 μg in young adulthood, and it should be maintained at 5 μg after the age of 25. So pregnancy and lactating mothers should increase the daily intake by 5 μg. So now, proceeding with the deficiencies, vitamin D deficiency. So first, rickets. It is the disorder in the vitamin D calcium phosphorus axis which results in hypomineralization of bone matrix. So the oral manifestations include developmental abnormalities of dentine and enamel, delayed eruption, malalignment of the teeth in the jaws, and higher caries index. And then proceeding with the osteomalacia, it is the adult equivalent of juvenile vitamin D deficient rickets. Unlike juvenile rickets, only the flat bones and the diaphyses of the long bones are affected. The disease is most commonly seen in postmenopausal females with a history of low dietary calcium intake and little exposure to ultraviolet light. It is endemic in certain areas of India, Japan, and China. So, the most common reported etiology is malabsorption. The oral manifestations is 50% incidence of severe periodontitis in a series of 22 Indian women with osteomalacia has been reported. And next, hypophosphatemia. It is a hereditary disease. It is transmitted as an autosomal recessive trait. The basic disorder is a deficiency of the enzyme alkaline phosphatase in serum or tissues and excretion of phosphatidylcholine in the urine. Oral manifestations are loosening and premature loss of deciduous teeth, chiefly the incisors. There are varying reports of gingivitis, however, it does not appear to be a consistent feature of this disease. And next, vitamin E. The generic name of vitamin E is tocopherol, which means the alcohol which brings forth offspring. Vitamin E has antioxidant properties. The main function of vitamin E is to prevent peroxidation of polyunsaturated fatty acids. Vitamin E consists of 8 naturally occurring tocopherols, of which alpha tocopherol is the most active. So, deficiency. Deficiency of vitamin E is very rare and occurs primarily in children who suffer from chronic cholestatic liver disease. So these patients have severe malabsorption of all fat-soluble vitamins, but particularly vitamin E. Multiple neurological signs develop as a result of abnormalities in the central nervous system and in the peripheral nervous system. The recommended daily allowance for vitamin E ranges from 3 mg of D-alpha tocopherol for infants to 10 mg for adult males. So increased intake in pregnant and lactating women is suggested, especially in view of the low perinatal levels of vitamin E in the infant. And next, the last vitamin, vitamin K. Unlike other fat-soluble vitamins, vitamin K or coagulation vitamin is absorbed from the gut and transported to the liver via lymph chylomicrons. Vitamin K was shown to involve intimately in both the extrinsic and intrinsic systems of coagulation, particularly with the prothrombin factor 2 synthesis and in the regulation of levels of factor 7, 9 and 10. There are 2 natural forms of vitamin K, namely vitamin K1, also known as phylloquinone, derived from vegetable and animal sources, vitamin K2 or menaquinone, synthesized by bacterial flora and found in hepatic tissue. Vitamin K3 or menadione is a chemically synthesized provitamin and it is water soluble. This is converted into menaquinone by the liver. Vitamin K deficiency. A deficiency of vitamin K may be seen in patients with malabsorption syndromes or in those whose intestinal microflora has been eliminated by long-term broad-spectrum antibiotic use. A deficiency or inhibition of synthesis of vitamin K leads to a coagulopathy because of the inadequate synthesis of prothrombin and other clotting factors. The oral manifestations include coagulopathy is most often manifested by gingival bleeding. If it is not corrected, that may even result from uncontrolled systemic hemorrhage. So the references include Schaeffer's Textbook of Oral Pathology, 9th edition, and Neville, Oral and Maxillofacial Pathology, 3rd edition. Thank you.